The IN.PACT AV Access trial is the first prospective randomized multicenter trial with large population examining the efficiency of the IN.PACT balloon in AV access. I would say that in its design, it's more like, it's one of the first level 1 evidence trial that demonstrates the efficacy of the IN.PACT balloon in reducing the target lesion revascularization, the number of reintervention, and the time to reintervention in AV access.
I was actually impressed and very pleasantly surprised to see that this paper was published in the New England Journal of Medicine. It's not very common to see papers about vascular access and fistula being published in this journal. And if anything, this is definitely suggesting that the paper and the data are very high quality. What we see in this paper is that we have a really significant improvement in terms of patency of the target lesion primary patency, but even in terms of the patency of the entire circuit. So these are, definitely groundbreaking data, especially given the slight disappointment that we had with a similar previous work that was done for a same type of balloon that didn't show these significant results. And furthermore, in terms of security and safety, we saw that at least for this cohort of patients, there doesn't seem to be any significant increase of mortality rates.
My reaction to the IN.PACT AV trial data recently published was that this is a really good, high quality study that clearly demonstrates a benefit of drug-coated balloon use versus angioplasty alone. There are several things which stood out for me. One was obviously the higher primary patency rates seen through at 6 months, but also the reduction in interventions by 56% when comparing the DCB group with the plain balloon angioplasty group.
The impact on the quality of life of our patient is probably huge, because we will have less reinterventions, less hospitalizations, and for these patients who already have many comorbidities and many time in hospital because of dialysis, but also because of the other disease, the time spent in hospital will decrease. So this is really a benefit and less pain for the patient.
Most interesting from this paper and very relevant to the actual clinical practice was that there was not only improvement of the target lesion primary patency, but of the entire circuit. And that was a significant improvement, as we can see very beautifully in the Kaplan-Meier analysis. What this means essentially, and it's coming out differently from many other papers, is that you're not only improving the patency for the target lesion, but you're improving the patency for the entire fistula, which is what matters for the patient. Because if we are improving only the target lesion primary patency, but the entire patency of the fistula remains the same, then someone might argue that there is no actual clinical benefit for the patient, because his fistula will come down anyway at the same interval as it was going to go down anyway. So I find this the most important and most relevant characteristic of this paper.
I think that sort of data has a significant impact when we think about our patients and our practice. So if I'm explaining to a patient the benefit of drug-coated balloon use when I'm consenting them for a procedure, I can talk about primary patency rates, but it often doesn't mean as much for the patient as the reduction in number of interventions. That means quite a lot for them, because often these are patients that have had multiple repeat interventions. And once we start talking to them about reducing the number and increasing the time interval between interventions, that's when that has an impact for the patient.
The implications for the practice are pretty clear. It means that now we should use drug-eluting balloons, and especially the IN.PACT balloon, because we have this data now, when we do an angioplasty for an AV fistula. What is important to say for the readership is that there were some populations that were excluded from this study. And so this study demonstrates a superiority of drug-eluting balloons when we do a stenosis, when we operate on a stenosis in a patient that is already on dialysis. But for example, some subgroups were excluded, such as the patient with balloon-assisted maturation angioplasties for young fistulas, and so on.
In terms of quality, the effect of this data coming out and the actual effect of using this product for dialysis patients, we have more direct effects, and I would say potential more indirect effects. So the more direct effect, for example, is that if you're able, by using appropriately this product, to reduce the number of interventions for this patient within a year, and let's say, for example, this patient, instead of having 1 or 2 interventions for his fistula, having none, or just 1 instead of 2 or 3, well, this is a big deal, because this will avoid 1 more hospitalization for the patient. However, there is also 1 more indirect benefit that relates with the improvement of dialysis. Let's say there is dysfunctional fistula that for some time is being dysfunctional, the patient is not getting good dialysis, or for patients that will get eventually a thrombosis and a catheter because we were not able to salvage their fistula. So there might be some indirect impact, not only by reducing interventions, but also by improving the dialysis, the quality of dialysis for the patients, and avoiding catheters and potential complications from catheter use.
I have always been an advocate of DCB use, and I use DCBs in my AV practice and have so for some time. I think what I would say is this adds weight to the use of DCBs, given that we have if we look at the timeline of DCBs, we had some promising studies, and then if you look in the literature, some of the smaller studies have demonstrated very mixed results. So we now have this high quality study demonstrating a significant difference between DCB and pain balloon angioplasty. So I think it hasn't changed my practice per se, but it has supported DCB use in my practice.